Hello students, welcome to the Indian Council of Medical Research Online Prescribing Skills course 2020 for the Indian medical graduate. I am Dr. Chetna Desai, Professor and Head, Department of Pharmacology, BJ Medical College, Ahmedabad, and today I am going to talk about prescribing diabetes mellitus. After viewing this video, please answer 5 multiple choice questions and give a feedback. You will find this in the assignment section. This module has been prepared by the ICMR RUMC Center at BJ Medical College, Ahmedabad by myself, my co-authors Dr. Prakriti Patel and Dr. Kartikeya Parmar. The module has been reviewed by Dr. Ratinder Jhaj from AIIMS Bhopal and Professor Dennis Xavier from St. John's Medical College, Bangalore. At the end of the module, the Indian medical graduates shall be able to diagnose diabetes mellitus based on the clinical presentation and laboratory investigations, prescribe rationally for a patient with diabetes mellitus using standard treatment guidelines, review the prescription and investigational reports to modify the therapy, monitor a patient of diabetes mellitus, judge uncontrolled diabetes mellitus and refer the patient to a specialist for treatment or change in treatment as needed. Counsel the patient regarding lifestyle modifications and importance of compliance to treatment in prevention of complications of the disease. Counsel the patient regarding reporting of symptoms of hypoglycemia and monitor, detect, prevent and manage hypoglycemia occurring during treatment. The prevalence of diabetes in India has increased to 20% in urban India and rural areas are also fast catching up. Diabetes has affected more than 72.9 million people in India. Around 7.1% of adult population in India is diabetic. India has the second highest number of diabetics in the world after China, and these numbers are projected to rise to 134.3 million by the year 2045. Also, nearly 1 million Indians die due to diabetes every year, which makes it very important for the Indian medical graduate to understand the management of this disease. The major types of diabetes mellitus are 2, that is type 1 and type 2, and diabetes mellitus refers to a group of common metabolic disorders that share the phenotype of hyperglycemia. Diabetes mellitus occurring during pregnancy is known as gestational diabetes and it requires special considerations during treatment. The pathophysiology of type 1 diabetes is autoimmunity leading to beta cell destruction. This diabetes is early onset diabetes and since the beta cells are destroyed, the patient is insulin dependent. On the other hand, type 2 diabetes mellitus is associated with insulin resistance. In type 2 diabetes, there is more insulin initially, but with years of stimulation of beta cells, it leads to exhaustion of beta cells of pancreas causing failure, and if the disease progresses, the type 2 diabetic patients eventually also require insulin. 3 parameters, namely HbA1c levels, fasting and postprandial and random blood sugar levels are used to diagnose diabetes mellitus, and there are various guidelines used for treatment of type 2 diabetes mellitus, of which American Diabetes Association guidelines and American Association of Clinical Endocrinologists, that is the AACE guidelines, are followed in India. But before we understand the management of type 2 diabetes mellitus, let us have a look at the common clinical signs and symptoms of type 2 diabetes mellitus. Patients of diabetes mellitus present with certain typical signs and symptoms like polyuria, that is excessive urination, polydipsia, that is increased thirst, polyphagia, that is increased hunger, a feeling of excessive tiredness, unexplained weight loss, irregular menstruation in girls and more common incidence of yeast or bladder infections. Laboratory investigations are important and diagnostic, particularly the fasting plasma glucose, the postprandial or the 2-hour plasma glucose after meals and the HbA1c, and based on the levels of these 3 parameters, the patients are diagnosed either as normal, pre-diabetic or diabetic. So, these are the values that are mentioned as per the guidelines. A fasting plasma glucose less than 100 mg/% is considered normal, whereas if it is between 100 to 125 mg/% it is considered to be a pre-diabetes stage, whereas if the FPG exceeds 126 mg/% the patient is diagnosed as suffering from diabetes mellitus. Similarly, the HbA1c level less than 5.7% is considered to be normal, 5.7 to 6.4% is considered to be pre-diabetic, and anything more than equal to 6.5% is considered to be diagnostic of diabetes mellitus. A1c level should be used only for screening the pre-diabetes, and the diagnosis of pre-diabetes, which may manifest as either the impaired fasting glucose or impaired glucose tolerance, should be confirmed with glucose testing. Glucose criteria are preferred for diagnosis of diabetes mellitus. In all cases, the diagnosis should be confirmed on a separate day by repeating the glucose or A1c testing. When A1c is used for diagnosis, follow-up glucose testing should be done when possible to help manage diabetes mellitus. The random blood sugar and fasting blood sugar are important also for titrating the dose of insulin. HbA1c is the gold standard for deciding the dose and choice of oral antidiabetic drugs and to check the compliance to therapy. Now let us understand the management of type 2 diabetes mellitus. Apart from regular monitoring through the laboratory checkup, lifestyle modifications including dietary control, regular physical exercises as well as medicines are the mainstay of management of diabetes mellitus. Let us understand the management of type 2 diabetes mellitus using some case studies. A 60-year-old female patient complains of easy fatigability since 6 months. She was recently seen at an outpatient department. Routine checkup showed her fasting blood glucose level was 123 mg/%. A subsequent hemoglobin A1c measurement was 6.4%. Her BMI, that is the body mass index, was 31.5 kg per meter square. She does not use tobacco or alcohol. How will you manage this patient? Now let us remember that the normal BMI is 18.5 to 24.9 kg per meter square, and in this case hence the BMI is increased. Now this is a case of pre-diabetic patient. Hence as per the AACE and ADA guidelines, the first step of treatment would be lifestyle modifications. The lifestyle modifications are particularly important if the patient is obese, since obesity leads to insulin resistance. The basic lifestyle modifications include calorie restriction, plant-based diet, diet rich in poly and monounsaturated fatty acids, exercise and adequate sleep. You could refer to the reference material for details on lifestyle modifications. Now this patient comes to the clinic for the follow-up as scheduled after 3 months. Her fasting blood sugar level is 160 mg/% and HbA1c level is 7.1%. On eliciting the history regarding lifestyle modifications that she was advised, it is found that patient was unable to follow these advice because of the knee pain that she was suffering from, and hence it was decided that the patient was best benefit from starting the pharmacotherapy. So now we need to understand why is it decided to start pharmacotherapy, and in case pharmacotherapy is to be started, which should be the medicine of choice for this patient. The reason why pharmacotherapy is advised is that if diabetes is left untreated, leads to microvascular and macrovascular complications. There is an increased risk of ischemic heart disease, stroke, polyneuropathy, retinopathy, nephropathy leading to blindness and renal failure. Hence it is very important to counsel the patient about regular blood sugar monitoring and control, and patient must also undergo all investigations for possible end-organ damage and comorbidities. Further details are provided in the reference material along with this module. So the basic management of type 2 diabetes mellitus that is recommended is that After diagnosis of diabetes based on standard diagnostic criteria, following steps are needed to be considered in the initial management. As we mentioned earlier, lifestyle modifications including weight management and physical activity, pharmacotherapy should be initiated. Usually tablet metformin can be started based on the lab report. However, it is advisable to avoid metformin in patients with severe chronic kidney disease if the glomerular filtration rate is less than 30, in presence of septicemia or in presence of significant liver disease and history of acidosis. If glycemic control is not achieved with step 1, that is lifestyle modifications and metformin, consider adding one or more of the following medications. Now, the other oral antidiabetic medications that are used are sulfonylureas, DPP4 inhibitors, pioglitazone, meglitinides, SGL2 inhibitors and glucosidase inhibitors. However, at this point let us remember that it is recommended that the patient requiring more than one oral antidiabetic therapy and not responding to lifestyle modifications and metformin is best referred to endocrinologist or specialized diabetes if the glycemic control is not achieved. This slide illustrates the step up management of diabetes mellitus type 2 that has been discussed earlier. And please remember that the goal of HbA1c in patients of diabetes mellitus should be less than 7%, and it is important to monitor the HbA1c every 3 months to show, and it is important to monitor HbA1c every 3 months to check the glycemic control of the patient. So, as we have seen here, the patient was prescribed metformin 500 milligrams twice a day and followed up every 3 months. The patient's blood glucose levels were well controlled for 3 years. However, on the recent visit, HbA1c was elevated to 7.6% as compared to the previous 6.6%. Patient adherence was confirmed. It was then decided to add another pharmacological agent. So, what should be the next step in the management of this patient? As discussed earlier, this patient needs referral to a specialist. The HbA1c levels are still higher and they are not yet controlled by metformin. The patient needs to be shifted to a dual oral antidiabetic therapy. The details of oral antidiabetic drugs are provided in the reference material along with this module. Apart from oral antidiabetic drugs, insulin is also used in treatment of diabetes mellitus. Insulin is the first drug of choice for treatment of type 1 diabetes mellitus. It is also used in severe cases of type 2 diabetes mellitus or when HbA1c is more than 10%. In that case, insulin is added with oral antidiabetic medicines. During pregnancy, insulin is safest for fetus and hence it is the preferred agent of choice during treatment of diabetes in pregnancy. Various types of insulin regimens are used for treatment of diabetes mellitus type 1 and 2. These include the sliding scale for insulin dose finding, the split mix regimen, the basal bolus regimen and the basal plus regimens, the details of which are provided in the reference material. Having learned the basic principles of management of diabetes mellitus type 2, let us learn about a common complication occurring during treatment of diabetes mellitus through this case study. This is a case of a 43-year-old female patient suffering from diabetes mellitus who complains of episodic confusion, blurred vision, tremors and sweating. These episodes have increased in intensity over the past year. She has been prescribed tablet glipizide for diabetes mellitus. Her random blood sugar is found to be 50 mg/%. Why is the patient having these symptoms? This patient is hypoglycemic, as you can see from the blood sugar levels, and this in this case is due to the excessive endogenous insulin secretion. Insulin and insulin secretagogues such as sulfonylureas and meglitinides cause increased insulin production and secretion, and these drugs can therefore cause hypoglycemia. Hypoglycemia is a relatively common complication of treatment of diabetes mellitus. An internet based patient survey showed that the event frequency of hypoglycemia is more or higher in patients of type 1 diabetes mellitus as compared to type 2 diabetes mellitus. Nonetheless, it can occur in both groups of patients. Also, it may occur at any time of the day, including at night, which means that the patient may miss the symptoms of hypoglycemia. There are several consequences of hypoglycemia, including neurogenic symptoms, tremors, palpitations, anxiety, sweating, hunger and paresthesias. In fact, these symptoms can be the warning symptoms which the patient should be counseled about so that he or she can detect hypoglycemia when it occurs and report to the treating physician. Recurrent or severe hypoglycemia is known to cause cognitive impairment, psychomotor abnormalities, abnormal behavior, seizures, coma and sometimes brain death. Hypoglycemia also results into rebound hyperglycemia and an inadequate control of diabetes known as brittle diabetes. Since the symptoms of hypoglycemia are very unpleasant, it is also a barrier to adherence to treatment secondary to fear of hypoglycemia. Patients are at a greater risk of dementia. Prolonged QT interval with increased risk of dysrhythmias and sudden death have also been observed, and patients may cause harm to property or to others, especially if they are driving when they are experiencing the hypoglycemic symptoms. So, what are the factors which put a patient at risk to hypoglycemia? As discussed earlier, use of insulin or insulin secretagogues along with any of the following can increase the risk for hypoglycemia. Like for example, missed or irregular meals, which is pretty much common in our Indian patients who are known to undertake regular fasts. Advancing age, impaired awareness of hypoglycemia as in patients who are taking for example beta adrenergic blocking drugs, unaccustomed exercise, taking greater than prescribed doses of medicines, excessive intake of alcohol, pre-existing impairment or sudden worsening of renal or hepatic function and concomitant medications like quinidine, salbutamol. These are all the various factors which put a patient to higher risk for hypoglycemia. As they say, prevention is better than cure, and as discussed earlier, recurrent and severe hypoglycemia can be dangerous for the patient. Hence, what are the steps we could take to prevent hypoglycemia? It is important to educate and counsel patients to set appropriate glycemic targets for individual patients. It is recommended that while the goals for glycemic control may be more stringent for young newly diagnosed patients with no comorbidities, they should be lesser stringent for elderly patients or for patients with limited life expectancy. We need to educate the patient regarding self monitoring of blood glucose, and also it is important to choose the appropriate therapy and individualize the therapy according to the patient and disease characteristics, and always hold a high index of suspicion for hypoglycemia. Further details of these preventive measures are provided in the reference material. Once a patient has been diagnosed with hypoglycemia, how do we treat it? More often than not, a patient may be brought to the outpatient department or the emergency. Diagnosis is confirmed if random blood glucose is less than 70 mg%. If the patient is responsible and can take orally, administer 15 to 20 grams of carbohydrate, preferably glucose stat. If the patient is not responsive, administer 100 mg of 25% dextrose intravenously. The 25% dextrose is to be repeated every 15 minutes till random blood glucose is more than 70 mg%. There are certain do's and don'ts for the patient that we need to educate them about. First, monitor the HbA1c levels every 3 to 6 months. Educate them to self monitor glucose levels 2 to 4 times a week. Maintain a diary of symptoms. Adopt recommended daily lifestyle modifications. Recognize and report warning symptoms of hypoglycemia. Always carry sweet candy or biscuits for use if symptoms of hypoglycemia are experienced. Undergo regular cardiac and ophthalmological checkups. Check urine for albuminuria periodically. Keep insulin pen devices if they have been prescribed in the refrigerator, and understand and follow the instructions for insulin injections correctly. The patient should be advised not to skip medicines, to consult the doctor if medicines are not well tolerated, not to change insulin injection sites without instructions from the doctor, not to change the dose of medicines unless instructed by the doctor, not to walk barefooted in order to avoid foot injuries, and not to skip meals. These are the various abbreviations that have been used in this module for your reference. These are further references that you could use, and these also include certain guidelines, standard guidelines. These are the references you could use for further in-depth reading. Remember to treat diabetes well and early to prevent complications. We acknowledge with thanks the contributions of the RUMC Committee of BJ Medical College, Ahmedabad, as well as Dr. Asha N. Shah, Professor and Head, Department of Medicine, GCS Medical College and Research Center and Hospital, Ahmedabad. Dr. Sandeep Bavadekar, Professor and Head, Department of Pediatrics, Topiwala National Medical College and BYL Nair Charitable Hospital, Mumbai. Dr. Shamil Sheth, Postgraduate Student, Department of Pharmacology, BJ Medical College, Ahmedabad, for their valuable inputs. Thank you for watching this video. Hope you are now ready for attempting the MCQs. Please access the MCQs, which you will find in the assignment section, and submit the answers. Please also submit the prescription evaluation as per the tutorial, which I hope you have already seen. Thank you and happy learning.